And we'll find out what you remember from class. Okay, as I mentioned, we're going to be looking at medical terminology. We're going to be looking at A&P. We're also going to be looking at anatomical terms. We'll be talking about directions and then landmarks. It will be probably new to you in most cases. We're also going to be looking at different body systems as we go through the anatomy and physiology. So let's see what you know. Anybody here, I think I've already asked you, a couple of you taken Latin, right? Yeah, this will be easy for you then. But most of our English words are made up of several parts. In medical terminology particularly, we're usually looking at prefixes, a root word, a suffix, some different combining forms. So once you know what some of those root words are, or some of those prefixes and suffixes, you'll know how to put things together, or actually break them apart to understand what they mean. And there's just no way that you're going to be able to know all the medical terminology out there. It just goes on and on. I taught medical terminology for years, and that's all, the whole semester was just, gee, medical terminology. And I don't know all the words either, so there's a lot out there to know. So we're going to focus on some key root words in particular. And as you read through your chapters, when you come across words that maybe you don't know what they are, try to break them down into parts so that you can understand based on their prefix and suffix. So for example, we know the root word is going to be the main word that tells you something like cardio, C-A-R-D-I-O, probably means what? Heart, certainly. So that's going to be a root word, and so we can put things before it and after it that would indicate what's going on specifically with the heart. Word here, thermometer, if you break that down, therm means what? Yeah, heat. And it's going to be a way to measure heat or coolness, either way, but particularly heat. So you can see how you've got a root word, a combining word, and then another word there. A prefix is going to be something that comes before. So this root word right here, P-N-E-A, can you think of a word that you're all familiar with that has this root in it?
Pneumonia?
Certainly, pneumonia, which has to do with air or breathing. So if you add something like D-Y-S, the prefix DYS means difficult. So if you add DYS with PNEA, what have you got? Difficulty breathing, right. If you add something to the end, we know arthro, arth right here, did I have that in here for you somewhere? Means joint. Itis, what's itis? Inflammation, yeah, so you've got inflammation of the joint. Sometimes you may have a compound word where you've got two root words together, like, for example, smallpox would be in English, but there'll be some that we'll see as we go through the semester. In your textbook, there's going to be a list of some medical terminology for you that you need to know. And as we go through the semester, I'm going to use some larger words that you may not be familiar with. And in most cases, if I remember, I'm going to define it for you and explain it to you, and I may do that a couple, 3 times. After that, I'm going to expect you to kind of know what it is. But if I do use a word that's unfamiliar to you, I mean, if you're kind of like, what does that mean? Raise your hand and ask me, because sometimes I forget. I also teach in class, in the mornings on the paramedic level, so I have expectations for them that I don't have for you. So if I use a term that's you haven't gotten to yet, just please ask me, because if you don't know what it is, I can tell you there's 15 other people in class that don't know what it is. They're just afraid to ask. All right, so other examples. Tachy, this would be a prefix that you need to know. Tachy means fast. We already said cardio, it's heart. Here we've got tachycardia. So tachy is what? Fast. Cardia, heart rate. It's going to be a fast heart rate. B-R-A-D-Y, Brady, does anybody know what that means? It's slow. So if I have Brady cardia, I've got what? A slow heart rate, that's right. We just had therm, so if I have hyper, what does hyper mean? High, yeah. So if I have hyperthermia, what's that? Yeah, too hot. Yeah, we got hot. We got the high heat. So if you have, what's hypo mean? Hypo is low. So hypothermia would mean no. That's what we don't have in here tonight, right? Okay. Hemo is blood. What's thorax? It's going to be the chest. So what do you think hemothorax means? Blood in the chest. Yeah, it's an easy one. How about, think of one of the earlier words, our P-N-E-U. What if we have pneumo, P-N-E-U-M-O, with hemothorax? Well, let me back up. What if we had pneumo and thorax? What's that saying? It ain't good. Yeah, it's air in the chest. So pneumothorax is air in the chest. So if we have pneumothorax, what have we got? Blood and air in the chest. Yeah, another kind of nasty condition. Okay, other parts, these are things you'll probably know if you think about ology. Can you think of some science you took that ends in ology?
Biology.
Yeah, biology, not like chemology, I know, right? Biology is ology is the study of. IST, it's going to be a specialist, like a, can you think of a specialist? The dermatologist, IST, that's right. All right. Okay, we're also going to be talking about different acronyms in here. An acronym is going to be an abbreviation made up of initials, like one we use with the sample. We talked about getting a sample history, and that's S-A-M-P-L-E, and we'll talk about those later. But there'll be quite a few that we'll use in here. And some other things you'll see, like CPAP. Or how many of you are familiar with CPAP? You know people that use that at night, you know, to help them breathe, CPAP. We use a form of it on the ambulances, and it's quite effective. CPAP, continuous positive airway pressure. It kind of blows air in and just kind of keeps a little bit of air flowing through there all the time. We mentioned this the other night, DNR, do not resuscitate. So there will be a lot of these as we move through. In fact, next week I'll give you a sheet that's got a bunch of abbreviations and definitions on there, some things that you can use when you're writing your reports. I wonder what was on there. Okay, what does anatomy mean?
Study of the body.
The study of, like, just the old body? Huh? Sort of. Come on, y'all got books.
Study of what makes up the body.
Yeah. Well, here anatomy, we're talking about the structure of the body. Correct. The study of the body's structure. What's physiology? How it works. It's going to be the function. Exactly right. So we talk about anatomy and physiology. As I mentioned, we can't cover all of it in here, but we're going to be looking specifically at the disorders that we're most interested in. So anatomy is going to be the study of the structure of the body, and physiology is going to be the function of the body. All right, here's the fun part. Let's see. Who wants to volunteer? Don't everybody jump at once. Give me some guy. Firemen, they always want to volunteer. Come on up. They make great guinea pigs. Let's see if they act up. I just reported you a sheet. That's easy. Okay. Plus, have you done this before? Yes. Oh, yes. Stand over here so you can't see the screen. And John can peek. Okay. Acting, right? Okay. Don't look. Okay, acting. Show me anatomical position. Yeah, you do. Yeah, you do. Come on. Anatomical position. Because you read your book, right?
Yeah, of course.
Yeah, okay. Who in here can stand up and show act an anatomical position?
I think it's in this one.
No, that's a religious symbol. Anatomical position. Come on, somebody. Someone can stand up and, Okay, thank you very much. Anatomical position is going to be upright with the palms facing out. Even though this doesn't say anatomical position, well, yes it is. It is. It's going to be this position with the hands facing out. And this is important because when we start talking about other directions, we need to know where we're starting from. I'm going to come back to this. Don't let me forget. I know you will. Okay, planes. And not like that. Anatomical planes. is show us your midline.
Middle here.
I just love that. Such finesse. Yeah, midline is going to be if we struck a line straight down the center from the front, just like this. This is midline. So if he has an injury out here, is it closer to the midline or is it distal? What does distal sound like? Distance, yeah, is further away. So when we talk about something that's median or midline, it's going to be closer or medial, whereas distal is going to be sound like distant, more distant. So our main reference point is going to be right down the center here. So that's the midline. Okay, if you have an injury right here, is that proximal or distal to your wrist? Think about these same terms here.
Let's bring it closer to the wrist and
Okay, so what will we call it? Okay, so it's proximal to the wrist, it's closer to the wrist, it's distal to the elbow. So if it was below the wrist, we would say it was distal. So distal sounds like more distant. And when we're trying to get our the point that our focus point, it's always going to be right in here somewhere, where it is from the trunk or the center of the body, as far as whether it's proximal or distal. Proximal sounds like it's approximate or it's closer to the center, whereas distal is going to be further away. Does that make sense? Okay, show me your mid-clavicular. Okay, what do you think clavicular is? The clavicle. The clavicle is also known as the collarbone. They tell me that's the most broken bone in the body. Huh? They say that. It hasn't been my experience. How many of you have broken your clavicle?
No.
That's it for you. How many of you have broken an ankle? Oh, how about wrist? Yeah. Okay, so what do we say? Do we think it's clavicle or do we think it's wrist? I think wrist holds it right here for sure. Yeah, they say clavicle. I've known very few people. Well, Tim broke his clavicle. But yeah, so clavicle's here. So mid-clavicular would be what? Point to it. Mid-clavicular.
that way, just in this area.
Kind of timid here. Let you ready, but yeah, mid-clavicular. If this is the clavicles, I would think mid-clavicular is here, but it's not. Mid-clavicular is going to be the clavicle on each side, so it's going to be the center point from here to here, and it's going to be right in here somewhere. So that's going to be mid-clavicular, and that'll be more important as you move up in the program because there's certain things that we would do based on that. However, we might use that as a point of reference. If he has a gunshot wound to the chest and it's right here, how do you think I'd write that up? That's just plain left mid-clavicular, isn't it? Sure. That made it nice and easy. All right, what else we got here? Don't look. Don't look. Okay, say you have a stab wound right here. Is that going to be distal or lateral? I mean lateral or medial, sorry. Is that going to be lateral or medial? What does medial sound like?
Middle.
The middle, that's right. So if this is, yeah, so if it's right here, it's what? Lateral, because it's going to be on the outside. Right, lateral is going to be on the outside. So medial, lateral, mid-clavicular. Hey, what's dorsal?
Like the fins on dolphins, the dorsal fin.
Yeah, the dorsal fin, yeah, which is kind of interesting. We talk about the dorsal part of the foot, really is the top part of the foot, where the fin would be. You know, if your foot were a shark, right? Your fin would be there. So that's going to be your dorsal. You know left and right, those are easy ones. We did midline. Okay, which part is your anterior part? Anterior?
Like 5 and 10 back.
Okay, here, I can make this easier for you. Which part is your posterior? What does that sound like? Yeah, that's right.
So it's that way.
Yeah, yeah, so your posterior is gonna be the back. So we won't make little jokes about your posterior when you're walking away. So, whereas we won't make jokes to your face, which would be your anterior.
Right.
Yeah. So, anterior, posterior. Anterior is the front, posterior is the back. All right. Other terms for those, dorsal, the back, and ventral is another word for anterior. I want to give us two. Oh, I have another one. Show us your mid-axillary. I know that's going to be embarrassing because we don't know what that is, right?
Yeah.
Okay. Don't do anything that's going to embarrass you because you can do this without embarrassing any of us. Mid-axillary. What's the axilla? Okay, everybody, point to your axilla. Anybody? Yeah. Am I the only person in here that knew that was your armpit? I don't believe it. Yeah.
I like to do
Yeah, I knew that. So your mid-axillary line would be where? Well, because it's like a plane. Like, turn this way. This is where your armpit is.
that. It's
You
going
go
straight down.
Yeah, yeah. It's going to divide you into anterior and posterior. Now, if you had a gunshot wound here, right here, what would we say?
Up in the mid-axillary.
Yeah, left mid-axillary. Sure. All right. That wasn't too bad. And we got proximal and distal, right? Okay. And when we use that, it's going to be, when we say proximal, use it like closer to. If it's proximal to the shoulder, that means the injury is closer to the shoulder. If it's distal to the elbow, that's going to be it's further away from the elbow. All right. Quadrants? Yeah, you can sit down. Yeah, you deserve a hand for that. Let me just remind everybody else to make sure you study those, okay? You were a good sport, thank you. I'll recommend you to your chief, or assistant chief, as the case may be. Abdominal quadrants. Now, at this level, we divide the abdomen up into 4 quadrants. Quadrants, that means what? 4. So we're going to have the upper right quadrant, the lower right quadrant, the lower right quadrant, the upper left quadrant, and the lower left quadrant. And there are different things that are contained within each one of these quadrants. Say you had a patient that had pain in the right lower quadrant. Can you think of anything that may go, oh, that might be blank?
Where at?
The what?
Appendix.
Yeah, appendix. It might be appendicitis in the right lower quadrant. How about the left lower quadrant? It's probably not a whole lot over there that concerns us. What about, can you think of an organ that really spreads all the way across the left and right upper quadrant?
Liver.
Absolutely, the liver, sure. So when we divide, this up, it's going to go right through the navel pretty much as the center point there. You can see where the location of the diaphragm is. We're going to talk about the diaphragm at length here in just a few minutes. It's quite high. Does that surprise you that it's so high? No? Okay. All right, let's see what else we got. All right, who can tell me what supine is?
Lay on your back.
Laying on my back, not laying on my front? Okay, laying on your back. There you go. Nice little guy on his back. We will transport a lot of our patients in supine position. What did I tell you it is if he's sitting up part way? I wrote it on the board. Fowler's, certainly, uh-huh. And we said prone is going to be on his front.
We trained that. We come out, yeah.
Laying down, prone.
It was very ducted, very long.
Yeah, so you just, what'd you do with his face?
Face down, and so we just picked him up from the stretcher out.
Okay, was he able to breathe okay?
He was just passed out.
Yeah?
Yeah, it
His
was,
face down on the pillow?
then they turned his head, but they found him in the hallway.
Okay. That's probably not the ideal position. How should you have transported him?
On the side,
Yeah, the recovery position. This allows him to keep his airway open. Plus, if he vomits, you know, he's not like vomiting and then just like sucking it up. So yeah, recovery position for all of your unconscious patients, provided they don't have any airway compromise or you know, anything else that you're having to treat. So yeah, if they're breathing okay blood pressure's okay, you can just put them on their side. They're just like unconscious. So, what's the other names for this position? Recovery position, I heard it. Shock position, or this would be left lateral recumbent. And that's a phrase you want to be familiar with. Lateral, side, recumbent. Left lateral recumbent. Why do you think left lateral recumbent is a little bit better than right lateral recumbent? Your heart's on the left side, so we should lay on the heart?
I don't know.
My heart's down here. Let's lay on it. Do what? Well, that's good. I always think practically, certainly. Outside of that, besides you want to throw it somewhere else instead of like on you. Why else might you put him on the left side instead of the right side? Think about the organs in the chest. What about the lungs? The lungs is the answer there, but why?
We have the one side bigger than the other, so that makes a difference.
Yeah.
Your left
Yeah.
is smaller, right?
Huh?
And your left side smaller?
Yeah, we got lobes to the lungs. So on the right side, and I'm telling you, I'm such an artist. What do those things look like? There's a lung. On this side, okay. Why is the right side bigger than the left side?
The heart is.
Yeah. How about that? Yeah, you only have 2 lobes on the left side, but you've got 3. So this would be a position where you could, it would assist them in breathing a little bit better. If you lay them on the side where they've got more capacity, it may be, it limits them just a little bit. So it's not a big deal, but just kind of keep it in the back of your mind. Given a choice, you want to lay them on the left side instead of the right side. So that's your first exposure to my artwork, isn't it? Okay, we talked about this. This is going to be semi-Fowlers or Fowlers? I'd probably call that Fowlers, and then semi more at a 45-degree angle. Now, we haven't talked about Trendelenburg. Did y'all read the book? Did it talk about Trendelenburg? Yeah, with Trendelenburg, they elevate the feet. Now, I left this in here because you may see it out there. We really don't use Trendelenburg anymore. They used to call this the shock position, where you'd elevate the feet. They used to think that it assisted blood flow back to the chest. Well, they found that most people with any kind of respiratory compromise or bleeding issues, chest trauma, that by raising the feet like that, it really did more harm than good. So we don't use this position anymore, Trendelenburg, but you may see it. Okay, y'all ready for body systems? I feel like we're going way too fast. Where's the sign-in sheet? Everybody get signed in?
I think so. And there's 2 lines.
Oh, that's right. This is good. Did y'all scare him off? Couldn't have been me. Okay, we're going to start going through the body systems now, so try to stay awake. Musculoskeletal system. What does that sound like? Break that apart. Muscles and skeleton. That's kind of like what? A and P, right? The structure and the function. Okay, the musculoskeletal system does a lot of things for us. When you think about the skeletal system, it's going to be what? Our skeleton. That's what gives our body form. And then the muscles and the other tissues are what provide the function, right? The movement. So we will look, when we look at musculoskeletal trauma, we'll look at this much more in depth. So one of the purposes of the musculoskeletal system is going to be to protect the organs of our body. So which would it be, musculo or skeletal, that does that protection?
Both?
Yeah, it's actually both. You might think initially that it's just going to be the skeletal system. Specifically, what parts of our skeleton protects our organs? Can you think of?
Rib cage?
Yeah, the rib cage is going to protect our organs in the chest. What about
Cranium.
others? Oh yeah, our skull protects that thing in there that we use every once in a while. Can you think of another large? Our pelvis, is that what you said? Yeah, our pelvis protects a lot of those other organs in there. So, we've got 3 major structures that protect. Also allows for movement. We could just be a blob of protoplasm and muscles and stuff, but without bones, we're not going anywhere. We're just going to like slink along the earth like a snake. Okay, the skeletal system, as we know, goes throughout the body. There's not a lot of bones specifically. You're not going to have to learn, is it 216 bones or 208? I can't remember. How many bones are there?
206.
206. I was pretty close, right? I'm not going to make you learn all those because I can't remember all of them myself. But some of the main ones, we already talked about clavicle. Who can show us the scapula? Oh, we got that one. It's going to be the shoulder blades. Xiphoid process. Yeah, y'all got that in CPR, right? The xiphoid process, it's a little piece of cartilage. It's pointed, kind of points back into the rib cage, so that's why we don't want to press on that. We know our ribs. How about the humerus? Okay, let's see. What was that game? Where's the humerus? Okay, yeah. It's going to be the upper part of the arm. How about the radius? Let's be specific here. Got it. Here's your trick. It's going to be on the side of the thumb, which is where we're going to check a radial artery when we check a pulse. So it's going to be on this side. So what's the other bone? The ulna, yeah. Okay, how about the patella? Oh, you got that one. Yeah, the kneecaps, the patella. Just checking here. We know elbow. Does anybody here not know elbow?
Funny bone.
The funny bone? Yeah. Yeah, that hurts thinking about it. Femur head. Where's the femur head? Yeah, it's way up here. You can't palpate that. But the femur bone is where? Big old, very vascular bone here. That's right. Knee, femur, patella. How about the tibia? The tibia is your shin bone, and it's the larger bone. And so what's the other one called? The fibula. Yeah, so you got those two little bones. You got the tibia, which is your big bone, and the fibula is like your chicken bone. It's pretty small. Calcaneus? Heel. Yeah, if you fall from a third story balcony and you land on your calcaneus, what kind of injuries do you think you'll get?
Broken ankle.
Probably break your ankles. You what? Yeah, probably your femurs, probably break a hip, might even get some spinal compression there. Just everything, all the way up. It's very painful. Okay, this is more stuff that you know. The skull. The cranium is going to be, the cranial vault is the bone part that holds your brain. What do you call these things here? Eyes. Anatomy. The orbits. Isn't that funny? The orbits, yeah. What does peri mean? Peri, round, yeah. Peri means around. Orbits, here's a word for you. Oh gosh, I probably can't spell it right now. Yeah, I probably did. Ecchymosis, anybody heard that word? Ecchymosis. Let's see if anybody has any ecchymosis. If I beat you with a stick, you would have this by tomorrow. If I slapped you around, how's that? Bruises, yeah. This is bruises, yeah. So bruising. Okay, so if I said, eraser thing. What does bi mean? B-I. Two, okay. If I said you had you got? Do what? Two black eyes. Absolutely. Two black eyes. Bilateral, that means on each side. Periorbital, it's going to be around the orbit. Ecchymosis, two black eyes. So don't let that intimidate you. If some doc writes that in the chart, bilateral, periorbital ecchymosis, you'll go, so he's got black eyes. Okay, other things to know. The nasal bone, of course, you know that. What is the zygomatic bone? The cheekbones. Mandible, jaw. Show me your maxilla. Two hands. It's where your mustache lays. Yes. Hope I don't have one. Okay, spinal column. Now we will look at the spinal column at length later on too, but you should know at this point that it's made up of 5 distinct sections. The cervical is going to be the top. It connects up to the brain, runs through the neck. The next is, of course, the thoracic, which is going to be the chest part of that. The lumbar, the lower back, sacral, and the coccyx. Which do you think, based on what you know about anatomy and physiology, which of these is going to be the most vulnerable areas?
Cervical.
Cervical and lumbar.
Cervical and lumbar. Why? Why is the cervical vulnerable?
Because your head lifts.
Yeah, you've got that big old head on top of that stick, right? Never a good idea. And so what else besides that? It's just the weight. Yeah, it's exposed. There's no real support system through here. I mean, most of us don't have, big old muscles in our neck unless you play football somewhere. What's the second area that's most vulnerable? The lumbar, because why?
It's where my bends the most.
It has to hold a lot of weight up, yeah.
Lower back.
Do what?
Aren't lower back injuries the most common?
Yeah, because of the lumbar is so vulnerable. Wonder why it's vulnerable.
Because your position, you do more on those positions.
Well, wouldn't that make the sacral even more? Yeah, they can be compressed. What makes the thoracic so stable?
Ribs.
The ribs. Is there any ribs down here? No ribs. Yeah, so the ribs stabilize this area. There are no ribs here. There's no protection here. Your last 2 segments are basically fused, so they're kind of stuck together. They don't move anyway. But this carries a lot of body weight. It has some musculature, not as much as you would have in the upper body, but there's no ribs or anything to support it. So those are going to be your 2 most vulnerable areas, the ones most likely to be injured outside of a traumatic injury, which we'll talk about here in a bit too. Okay, the pelvis, quite a few parts of the pelvis. When we assess our patients and treat our patients, we really can't differentiate at this level where the damage occurred, where the break was, or how many breaks there are. But the ilium is going to be the top part of the pelvic girdle. You can see the femur head. I mentioned that a little while ago. The femur head really is the ball part at the very top of the femur. And this is very commonly broken. These are the ones, when Granny falls and breaks her hip, it's very common that she's broken off that femur head. Sometimes they break the ilium up here, but femur head's very, very common there. Okay, lower extremities, I think we've already been through these pretty well. What do we miss? The phalanges. What are phalanges? Yep. How about your, where else are they? Toes, that's right. How about metacarpals? Where are they? In your feet, yeah. And in your hands. We said tibia, we did fibula. We've done now phalanges. Malleolus, what is that? Well, here's a tip. There's a medial and a lateral. So what would the medial malleolus be? The inside ankle, whereas the lateral would be the outside. Haven't we been through these? Yeah. There are several different types of joints in the body too. This example, when did we just talk about that? What does that look like? It looks like the femur head there, doesn't it? Where will we see this one, you think? Yep, maybe the arm. I like them turned sideways. So you may have to have them listed out. Yeah. The ball and socket of the hip, and then a hinge joint like the elbow, like this. Looks like that. Okay. Are we going quick or what? All right, we're going to look at the different types of muscle tissue. And we've got three main types of muscle tissue. Skeletal muscle tissue. Skeletal muscle tissue does what for us? It allows for movement. That's right. Is that voluntary or involuntary? Yes. Arm move. Pretty good. How about smooth muscle? What does smooth muscle do? Wait, what? Yeah. Most of your smooth muscle tissue allows for stuff to move through it. So the muscle tissue in the esophagus would be what? Smooth muscle. How about the muscle tissue that forms veins and arteries? Yeah. How about your intestines? All that smooth muscle. Is that voluntary or involuntary? And that's going to be involuntary. How about cardiac muscle? Yeah, where do we find cardiac muscle? Oh, good. I'm so glad you got that. That was really going to concern me. Is cardiac muscle voluntary or involuntary? Involuntary. And it's only found in the heart. Let's see if we covered everything. Oh, well, that went way too fast. There's something else special about cardiac tissue. The A word. Anybody know what that is? Automaticity. Yeah. Break that down. Auto means what? Auto, automatic, or me by myself, me only. Automaticity, of course, that would be hard to break down. Automaticity means that the heart tissue is able to generate its own electrical pulse. It's able to generate electricity, if you will, and conduct that through the heart tissue. No other tissue in the body is capable of doing that. So automaticity is going to be the key to cardiac tissue that sets it apart from all the others. Y'all ready for the respiratory system? Okay. And these, when we get to each disorder, like when we look at respiratory diseases or cardiac issues, we're going to break down these systems much more in depth so that you understand them a little bit better. Okay, the respiratory system, what am I missing up here? What's the purpose of the respiratory system?
Gas exchange.
Yeah, to bring air in so that we can have gas exchange. Where does gas exchange occur? In the alveoli, that's right. So if you look at this picture here, how's this guy, how's he going to take air into his body? Through which places? The mouth and the nose. We don't bring it in through our eyelids, do we? I was watching Bull Durham last night. It was on. Y'all ever seen that? It's a scream. Anyway, that guy's breathing through his eyelids. Okay, we don't do that. So yeah, so air's going to come in through the mouth and the nose. What's the function of the mouth and the nose as far as the nose in particular doing something for the air? It filters it or cleans it. What else happens when you go besides filtering the air? Yeah, things I don't want to smell usually. But as far as functioning to help our bodies, well, it brings the air in, which is important, but it cleans the air. Okay, how many of you guys have ever been on oxygen before? Where they put a mask or nasal cannula? And you've done that for a while. Do your heart start getting real dried out? You know? No? Remember your nose getting dry, your mouth getting dry? Yeah, if you're not breathing normally and your system's not working right, then that air is going to be very drying. But the purpose of the nose, one of the purposes is to humidify the air. It's much more comfortable to humidify. That's one of the problems when you put a person on oxygen therapy for a long period of time. That oxygen is very drying. It's there's no moisture to it. So it humidifies the air. It cleans the air. It what? That's humidifies. You said moisture. That's fine. Okay, it's really, really cold outside. And if I breathe that air straight in from here and it shows up in my lungs at 32 degrees, what are my lungs going to do? They're going to fight back. They're going to kill me. So one of the things that occurs when you breathe through your nose and mouth, it warms the air. So yeah, the nose is very important. It warms it, humidifies it, as well as cleans it. So respiratory system, we bring air in. Once the air passes the mouth and the nose, where does it go? It's got to go somewhere. Does it go straight to the lungs? It's got to pass by something. It's going to pass by these structures. And if you look at each one, the nasopharynx, where do you think that is? Pharynx basically means space, kind of. So the nasopharynx is going to be what? Yeah, the space behind the naso, which is the nose, right? Oro means what? Not gold. Means mouth. That's right. So an oropharynx is going to be what? The space behind the mouth. Right, so we call this whole part back here the pharynx. And that's just going to be the open space behind the nose and the mouth. So at the very bottom of this space, we would call that the hypopharynx. And that's not on here, but that's okay. But all that air is being warmed and humidified, and now it's ready to go somewhere. So it has two choices of where it goes, right? I'll put my little pen thing. Did y'all hide it? Yeah. Afraid I'm going to draw. Okay, so after you breathe air in, there are a couple of choices of where it can go. There's your head. Here's your hairdo. Your ears. Oh, that's Dr. Spot. How's that? Oh, help me, Mr. Bill. So you take your air in, and you basically have two tubes. You got one on the front and one on the back. Like, consider you're laying down, not in an anatomical position. We can do some anatomical position up here. I hate it when players do that. That's all right.
I hate it for worse things. Just face these guys.
Okay, so he's got a tube right here on the front where you can see his Adam's apple, right? And he's got a tube behind it. Which one of those are we going to breathe through? The one on the front or the one on the back? The one on the front, and that's going to be called the trachea. You can tell, you know, you've got your Adam's apple here, and we're going to talk about some of those structures here in just a few minutes. So what's the one that runs behind it? The esophagus. Where does the esophagus go? The stomach. Okay, so which one of those do we want the air to go to? The front. I was going to go down the front. Absolutely, the trachea. If it goes down the esophagus, what's going to happen? You going to burp? Yeah. The bad thing happens. Yeah, somebody said it. Throw up. Yeah. Get a lot of air in your stomach. The stomach goes, it didn't belong here. So it starts throwing up, and you just hope it, like they haven't just had spaghetti or something. Okay, so the air is going to move through this little structure right up here. We were talking about the Adam's apple just a minute ago. But right through here is the larynx. The open space up here was the pharynx. This place where our vocal cords are is called the larynx. So the air moves in, the air moves out, and that's what allows us to speak. So it's going to move through the larynx and down the trachea really officially ends here. It's going to go down to the bronchus here and into the lungs. Now at the top of all this stuff, what is there to keep food and stuff from going in the trachea? To keep it from going in the trachea. The flipper? The epiglottis, that's right. So the round hole at the top is, of the trachea is called the glottic opening, and there's a little flipper at the top called the epiglottis, and it's like, it allows the stuff in and out. So it's going to open to let air in, it's going to close anytime you swallow, right? Try that yourself. You can feel your epiglottis closing if you swallow. All doing that? Yep, doing that. So, as we sit here, what do you think the position of the epiglottis is? Okay, let's take a vote. Who all think it's open?
It has to be one or the other.
It's got to be one or the other. Who all think it's closed? Okay, for those of you that's epiglottis is closed, you're going to pass out soon. And the rest of us will be waiting. We love that. All of a sudden, classmate passes out. So yeah, if it's closed, that means you're swallowing. If it's open, that means you're breathing. So if it's closed, you ain't breathing. So I like the breathing thing, so we kind of leave it open. So epiglottis is going to be up at the top here. We swallow, it's going to close. That's going to protect it to keep stuff from going down it, so it'll go shoot down the other way. Now when we look at that Adam's apple here, we really have three parts to this cartilage, and that's exactly what this is right through here. The larynx is made up of cartilage. But we've got three parts, Mr. Bill. Basically we have a pretty good sized cartilage here, a smaller cartilage here, and then it continues on down. So this top cartilage is going to be your thyroid cartilage. The bottom cartilage is your cricoid cartilage. So there's a space in between that's going to be your cricothyroid membrane. And whenever they do a needle cric on you, they're going to, in the field, they're going to put it right through there. So when you're palpating, that top notch is going to be your what? Your thyroid. You'll feel a smaller one just below that. That's going to be your cricoid. That's right. Good work. So if you had a patient that had a stoma, what's a stoma? Yeah, it's like a hole into the trachea for a patient to breathe. Some patients it's going to be permanent in that it stays there all the time. It's healed over. It's just like a hole. You just kind of look at it and go, oh, is that hole is there? Sometimes it may be permanent. Say they had to do that in an emergent situation, and it will remain until they clear up all the other issues, and then they may close it. So that's something that you need to remember, because later on we start looking at ventilating a patient. If you have trouble ventilating a patient, you know, you're pushing the bag, and where's the air going? You might consider that either they have a stoma that's flowing out there, or they don't have a complete, the stoma is incomplete, and the air may be rushing out the top. So you've got to be able to think about what could be interfering with your ability to ventilate. Okay, let's look at the rest of the airway. So as you come down here, the trachea, the point where we say trachea bifurcates, what does bifurcate mean? What's bi? Two, that's right. So what do you think bifurcate means? Where one becomes two? Yeah, that's going to be the point where it splits. So that's going to be the carina, the point where the trachea splits into two bronchi. So it's going to split at this point, and it looks like kind of, in real life, it looks like upside down trees. So these branches are going to get smaller and smaller and smaller. And there's smooth muscle tissue that's wrapped all the way around these, all the way around the airway. So if you have a patient, say, with asthma or an allergic reaction, those muscles are going to tighten up in there and constrict the air flowing through there. Does that make sense? So it's all going to go down to the terminal end, which is going to be the alveoli, or the alveolus, which would be singular. And this is where gas exchange occurs, in the alveoli. And you need to know that. And it's important because this is the only place that gas exchange occurs. Gas exchange does not occur up here. No gas exchange here. When I say gas exchange, we're talking about oxygen getting onto the red blood cells, and the opposite when waste products and carbon dioxide are offloaded. That's gas exchange. Just bringing air into the lungs is not gas exchange. It's just like I can pour gasoline into my car, but it's just going to sit there in a reservoir. It's not going to be actually exchanged or used until I crank it and try to drive off. Same thing here. You can put air through here, but if the person's not breathing, there's no gas exchange. Does that make sense? So the alveoli, and notice this little shape. They look like little clusters of grapes through here. And we'll look at some disease processes that actually break down these walls so that instead of having lots of little surface areas, it becomes flat, which really decreases the surface area. So those people are going to always have respiratory problems because they don't have much area of gas exchange. So we've got the left and the right bronchus. Now this you can kind of see, they kind of try to make a little showing that that lung is a little bit smaller there. But the heart is going to be right here, and that takes up that extra space. That's why the left lung is a little bit smaller. So we've got 3 lobes, they're kind of drawn here, but we only have 2 lobes on the left side. And then the diaphragm runs right here at the marginal bottom part of the lungs. And the diaphragm, when it's in a resting state, it's like this. And that would be when you exhale. It's going to go up like this. But when you inhale, your chest expands. That's going to drop down and pull the chest with it. That's what opens up the lungs to allow you to breathe. This is very important. And like I said, we'll talk about that at length later. So the main purpose of the respiratory system is going to be bringing in oxygen for gas exchange and then allowing for the release of carbon dioxide and other waste products through exhalation. I have the other stuff in here. Yeah. So inhalation, that means when you breathe in, that's an active process. Your body has to work to do that. Notice when you're ready to take a deep breath, things start happening in your chest. Your chest muscles tighten, your diaphragm drops down, and it's work. You're pulling against negative pressure in your chest. And if you keep your mouth open while that's happening, air should rush in. The diaphragm, the intercostals contract, the diaphragm moves downward, but it's the negative pressure that's the key here that allows the air to rush in. Exhalation is just the opposite. That's going to be a passive process. If you just sit here and just relax, the diaphragm relaxes, and when it relaxes, if your mouth's open, that air is going to leave. You don't have to work to have that done. It's going to happen naturally as long as your mouth is open. The other is going to be where you have to work for your diaphragm to drop down so you can breathe. So positive pressure is what's pressing that air out. So negative pressure is going to be the inhalation, bringing air in against pressure, whereas the exhalation is going to do it just naturally, passively. The only thing key in this photo is going to be the position of the diaphragm. So I may give you a photo like this, and I'm going to draw the diaphragm in, and I'll have you tell me if he's inhaling or exhaling. Does he have full lungs or empty lungs? So, in this position, do we have full lungs or empty lungs? Full lungs, that's right. This is when they're relaxed, so we're going to have empty lungs. Good work. The opposite's true with exhalation. So if we're like this, we got full lungs or empty lungs? Full. Here we've got empty lungs. So think about what happens when this diaphragm drops down like that. Think about all the other organs and stuff that sit around here. Can you think of one in particular that lays right here? Yeah, your liver lays right here. So in this position, the liver's up higher. And if you think about where the ribs fall, when you're exhaling, is your liver more protected or less protected? Yeah, when you're exhaling, when this is relaxed, the liver's going to rise and it'll basically be at the edge of the ribs. Whereas here, the liver's greatly exposed. So if you think about what usually occurs when you're about to have a wreck, I know y'all have seen all those jokes about, hey, watch this. Here, hold my beer. So they run off the road. No? Okay. You know, you're about to hit a tree. You see it coming. What's the first thing you do? Just before you yell something awful. Yeah, you take a deep breath. Your diaphragm drops down. All those organs that are close in here drop down, so they're much more vulnerable. So that's why we see a lot of abdominal injuries, you know, in a wreck where somebody can see it coming like that. Do what? Yeah, it just catches you when it catches you. That's why drunks do so well, I guess. All sorts of theories about that. Okay. We need to understand the difference between ventilation and respiration. I bet you guys know this. Ventilation would be what? Can you ventilate a dead person? Sure, they're dead. I'm just pumping away. You can ventilate somebody. Yeah. I can ventilate my kitchen when I catch something on fire in a toast oven. Get the air in and out. Ventilation is just going to be the movement of air in and out. Respiration, in order to have respiration, what has to happen? That's that gas exchange. You have to have gas exchange. So if a person is dead, we can ventilate them, but we can't make them respirate. We can't force an exchange of gases. That's only going to occur basically with a live person. So ventilation is going to be the movement of gases to and from the alveoli. So say if the alveoli are diseased and all ate up and scarred over and nastified, we can get air to them, but what doesn't happen? We can't force them to respirate. So we can get air to them, but we can't make them exchange gases.
It's like somebody's on a ventilator.
You can ventilate them, but hopefully if they're on a ventilator, they're still alive, so their body will respirate. But yeah, they're just providing the air to them. What happens after that will be up to the individual. Respiration is going to be exchange of gases, really, in a couple of places. I don't know if I have it on here now or not. I don't think so. We've got internal respiration and external respiration. What do you think external respiration would be? Because respiration is going to be the exchange of gases, right? Where is that going to occur? Y'all read your books. It should be in there. Y'all got to wake up. Close. That's going to be external respiration is going to be a gas exchange that occurs in the alveoli. You get the air there. There's gas exchange occurs. Because you get carbon dioxide and the waste products that are returned to the lungs. They'll be expelled into the lungs, and then oxygen is brought on. They call that external respiration. I guess because there's an opening to the outside. Internal respiration is going to be the respiration that occurs at the cellular level, out in the body parts. And you may see that on registry. Okay, what do we got here? Same thing. So when we breathe that oxygen in, it's going to pass through the alveoli, and what's it going to grab onto? The red blood cells. And what part of the red blood cells? Starts with the H. The hemoglobin. See, when you wake up, you know this. Just teasing you. The hemoglobin molecule. And hopefully we're going to have enough hemoglobin on every red blood cell to attach itself to the oxygen. So at the alveolar level, it's going to grab on there, and it's going to move throughout the body wherever it's needed. And then when it gets to the capillary beds, that's where they're going to start exchanging the gases again. What happens to it? The oxygen jumps off, goes where it's needed. And what does it bring on? Carbon dioxide and other waste products. And then it travels back through what system to get back to the lungs? The veins. Do veins carry oxygenated blood or deoxygenated blood? Who walked into that trap? Huh? Veins move towards the heart. Arteries move away from the heart. In most cases, veins carry deoxygenated blood, but sometimes they carry oxygenated blood. We'll look at that after a while too. But yeah, so that gas exchange occurs where the blood's going to pick up, or the hemoglobin is going to pick up carbon dioxide and waste products and then deliver that back to the lungs for gas exchange. Okay, we're going to talk about the differences in pediatric patients at length when we get to that chapter. But just very quickly, I want to make a couple of points. A pediatric airway is quite different than an adult airway. Besides, Josh, it's smaller. But it's more flexible. It's actually more narrow comparatively than our airway is. Some of these other things don't really matter, except the tongue is quite large in the head compared to ours. That means it takes up a whole lot more space. That means it's more likely to block the airway. The most common cause of a blocked airway in an adult unconscious patient is going to be the tongue. So you can imagine with a child, with it being that much larger, all it takes is a little bit of swelling in there, or if they're unconscious, it just takes up so much space that it greatly increases their risk for airway blockage with that. But probably one of the most important things that lead to a blocked airway in pediatric patients is going to be the shape of the pediatric airway. We've already talked about these parts on the adult. So the smallest part of an adult airway is the glottic opening. So what's that near? The epiglottis, yeah. So the smallest part of an adult airway goes like this. The glottic opening. This is kind of shaped like an egg for an adult. How's that? It's just the opposite on a pediatric airway. It's shaped more like this. And this would be their glottic opening. But right down here is going to be their cricoid membrane. That's going to be the smallest part of their airway. So you can see adults don't choke because big things can't get through there. But kids choke because big things can get through there. And it'll get stuck way down here. You know, it actually moves through the vocal cords and will get stuck here. So the smallest part of a child, pediatric, is going to be the cricoid for child. Is that going to help you remember it? Sure, I'll remember it now. All right. We'll go over that again. Okay, the cardiovascular system. The cardiovascular system is made up of more than just the heart, right? What are the parts that make up the cardiovascular system? The heart, the blood vessels, the vascular system. Yeah, that's going to be part of the parts. The parts of the heart, parts of the vascular system. Okay, how far am I going to get in my car if I don't have transmission fluid? Yeah, not too far. Or if I don't have brake fluid. I don't have oil. Okay. So, what are the parts of the cardiovascular system? We've got the parts of the heart, the vascular system, the blood. Yeah, we got to have fluid moving through that. So we got three parts. We got the heart, which is the pump. Any car guys in here? Is that it? You guys should be embarrassed. One car guy? We have people that are fibbing here. Y'all should be going, yeah, I'm a car guy. Yeah. Well, see, you car guys will get this. The rest of you, y'all may have to help them out. Okay, so the heart is the pump. That's going to be what provides the engine, provides the motor action. The blood is going to be the fluid. Got to have something to spread around, right? And then the circulatory system is going to be the pipes. And this is important because if any one of these parts fail, you are what? Yeah, you are SOL. That means you're stupid, lazy, and what? Yeah, you're pretty well toast. If any one of these fail, if the pump's not working, does it matter how much blood you have? Does it matter how great your vascular system is? Pump's dead. The pump works really good. I got great pipes. But what? I missed something. If I don't have any fluid, we ain't going anywhere. So yeah, if we got a good pump and lots of fluid, but the pipes are broke, it's all spilling out somewhere, right? So if stuff's all spilling out somewhere, what's happening to your patient? They are bleeding to death. Yeah. Okay. The heart. You know what? Let's take a break because I'm going to kill you with this heart thing, okay? It's 10 after 6. Give yourself about 10 minutes. Then come back. Okay, the heart. This will be the fun part. You're going to have to understand the circulation through the heart in order to do well in this class. And for some reason, students usually struggle with this. Years ago, I had a girl in my class, a lady, in fact, she was a nurse. She'd been a nurse for 20 years. And after the cardiac lecture, she came up to me and she goes, you know, now I finally understand the heart. So let's make sure when we leave here, we're going to understand the heart. If you don't, get with me because it's not that complex, but you do have to understand it so you can better diagnose what's wrong with your patient. So that's going to be the foundation of what we're looking for. You can imagine that if blood backs up on this side of the heart, which is where the blood comes in, if blood backs up here, we're going to get different signs and symptoms than if blood backs up on this side of the heart. So we're going to talk about why that occurs and the flow through the heart. So, blood is going to return to the heart through the vena cava, and of which we have two. We have a superior. Where would the superior vena cava come from? The top, certainly, the superior part. I don't think we talked about that, superior, inferior, did we? superior is going to be the top, inferior is going to be the bottom. So the superior vena cava is going to actually bring blood from this part. It's going to drain the head, the neck, and the top part of the shoulders. Those are going to be drained by the superior vena cava. The inferior vena cava is going to drain everywhere else. This is going to be the venous system that's returning blood flow from the body back to the heart. So when it gets back to the heart, why is it going back to the heart? Just so it can start all over again?
To oxygen and carbon dioxide.
Yep. So it can pick up oxygen and offload the carbon dioxide and waste products. So the blood, when you look through the pictures, deoxygenated blood is always going to be signified by the blue. Oxygenated blood is always going to be signified by the red. So that can help you kind of remember the blood flow. So we're going to have the vena cava that bring the blood, deoxygenated blood, back to the heart. So the heart has 4 chambers. I'm going to keep it simple for you, because you saw what my heart looked like, right? Heart doesn't really look like this. So what would this chamber be? Now, let me, when we're talking about positions, and I didn't mention this, anatomical position, right? Here's my heart. You're always talking about the patient's left and right. So if I point to this and say, which one is the left ventricle, you're going to know that's going to be on the patient's left side, not your left side, okay? So, what chamber is this one going to be?
Right atrium.
The right atrium. And the atrium is always going to be at the top. The ventricles are always going to be at the bottom. So, if this is the right atrium, what's this one? Right ventricle. Now, and then, so what's this one going to be? Left atrium, left ventricle. Okay, we got that part? We know left and right, top and bottom. Now, blood is going to return to this chamber, the right atrium. That's right. It's going to come in right here. Little drop of blood flow. Where is it going to go? It's going to come to the right ventricle through. Anybody know what this valve is? This is the tricuspid valve on the right side. So blood is going to flow through here, flow through here. Where does it go next? That give you a tip? It's going to go to the lungs. So this is deoxygenated blood, and it just kind of gathers in here. The atria are holding ponds, basically. They're going to gather up the blood. It's like you're filling your bucket up. When you get enough in there, it dumps it over down into the right ventricle. From here, we've got deoxygenated blood, and we need to get oxygen, right? So from here, it's going to split out and go to the lungs. And in the lungs, it's going to drop off what? Carbon dioxide, waste products, and pick up oxygen. So now we have oxygenated blood, right? And so from here, from the lungs, where is it going to go back to? Yep. It's going to come back to the atria. And this I have to, well, for my drawing, I'll bring it this way. So all blood here, when it leaves the right ventricle, it's going to go to the lungs. When it returns, it's all going to return to the left atrium. So, atria always, blood always returns to the heart into one of the atria. So if it's returning to the heart, it only returns to the atria. When it leaves the heart, it's only going to leave from the ventricle. Does that make sense? So the blood's going to, this looks really bad. I told you I was a great artist. So yeah, so the blood is going to come back to the upper chambers, and then the lower chambers are your workhorse. Your ventricles are the ones that pump. Your top ones don't do much pumping at all. Gravity moves most of your blood down to the lower chambers. Then the lower chambers Those are your workers. That's where your pulse is generated. That's where the contraction is what sends the blood on. So think about this. Which one of these two chambers has to work harder? The ventricles.
Oh, the right.
Well, think about, where is the right ventricle? Where is it pumping blood?
The left ventricle is the hardest.
Did I say left? The right. The right pumps it to the lungs. How far is that? Okay. The left pumps it where?
Whole body.
To the toes, to the brain. So which one of these is going to work harder?
The left.
Yeah. Over here, I was messing over the lungs. No big deal. Over here, big workhorse. So where do you think most heart attacks occur? It's going to be the left, because that's the one that's got the most muscular tissue. It's the one that does most of the work. So that's the one that you're going to have your biggest problems with, because it's your worker bee. Forgot to mention the bicuspid valve. What's the other word for the bicuspid valve? Starts with an M? The mitral valve. That's right. So it's going to move through a valve as it moves from the atria down to the ventricles. What else do I need to tell you? This is the septum. It's going to be some muscular tissue that separates these ventricles. Also, this is part of the muscular system that causes them to contract too. All right, so what did I tell you about veins? What do veins do?
Bring blood to the heart.
They what?
Bring blood to the heart.
Yes. Veins move towards the heart. Arteries do what? Move away from the heart. Don't get caught up in the oxygenated, deoxygenated. Veins move away from the heart. Veins move towards the heart. Arteries move away from the heart. So, when the blood is leaving the right atrium, it's leaving the heart to go to the lungs, what's that vessel called? It's pulmonary
Artery.
artery, because it's moving away from the heart, right? So pulmonary artery carries deoxygenated blood. So if you remember, arteries move away from the heart, veins move towards the heart. So from here, these are the lungs. You want me to draw on those? You don't see me drawing here. I'll draw you a lung. There. So when I'm sending blood back from the lungs to the heart, what's it going through? Pulmonary vein, because it's moving towards the heart, even though it's carrying oxygenated blood. Here, watch me erase this. What else I need to tell you? This is important. The top of the heart is called the base, and the bottom of the heart is called the apex. I didn't invent that. That's crazy. The top of the heart's the base, the bottom of the heart's the apex. And I think I pretty well covered that. Oh, the aorta, that would be important. The aorta is the major vessel that takes the blood out of the heart and back through the vascular system. It's going to be this giant artery, and this is it. And up here you can see you're going to get branches that go off the aorta to feed the other parts of the body. It's pretty simple, but that's what we have. Questions about that? We will go over this multiple times before we're done. Okay, let's talk about the cardiac conduction system. Remember we were talking about the pipes and the fluid and the vessels, right? Now we're adding a component here, the conduction system. So in a car you have to have an electrical system, at least you do now. This is our computer system, if you will. So the conduction system is very important. Say everything is healthy here. I have a healthy heart. I've got good blood. I've got good pipes. But my battery's dead. How effective is my heart going to be? It's kind of like the light switch. I've got a good light bulb in here, and I flip the switch, but nothing happens. There's no current going through there. So that's the important part of the conduction system. We've got to have that electrical impulse. What did I tell you about cardiac tissue? It's capable of what? The A word. Automaticity. Yeah, so it's going to generate its own electrical pulse. If everything else in your body was dead except your heart and the electrical system kept working, it might keep pumping even though your brain is dead. So the conduction system, the cardiac conduction system is pretty handy. Now there are several components of it, and you need to know these guys. So your heart's just kind of laying there, flaccid, and it goes, you know what? I think I need to get going. I better generate my own pulse. I better get some electricity going here. It's all going to start here at this SA node, the sinoatrial node. You notice that it's in the atrium up here, right? Sino actually is from sinus. Sometimes we'll call this the sinus node, the SA node or the sinus node. And that's where the electrical impulse is first generated. It's going to start there. And recognize that this electrical impulse has to go throughout the whole heart. It's not just a direct line like I turn the switch on and it goes directly to the lights. It has to spread throughout this whole organ in order to cause it to contract. And so I don't want this part to start contracting as soon as it gets an electrical impulse, and this one comes on, this one comes on. It's not like you're in a giant, convention center. You flip the lights, and it takes it, 10 seconds for them to spread all the way across and come on. You know what I'm saying? Are you following that? Yeah. We don't want it to do that because then it's going to be firing chaotically, and we're not going to get a good pulse. So they all have to fire together. So the impulse is going to be transmitted down here to this second little node, which is called the AV node, the atrioventricular node. So atrial means it connects the atrium to the ventricles. So it's going to be the AV node, the atrioventricular node. And what it does is it holds up that impulse and allows it to spread all at once from the bottom, so that as it contracts, it's going to contract from the bottom and force that blood out, which is what we want it to do. So we have the SA node, or the sinus node, which starts it. We've got the AV node, which kind of acts as a junction box, kind of holds it up for a second, and then sends it on. And then these guys are called Purkinje fibers. Right up at the top is what we call the bundle of His, which is a bundle where everything branches out from into the Purkinje fibers. So these Purkinje fibers are just like little tentacles or little fingers that spread all around the ventricles on the bottom. And as soon as it gets that impulse, everybody gets an impulse, and then we're going to spring all at the same time. So that's going to be our conduction system. And later on, when we look at the cardiac chapter, we're going to look at some different rhythms and try to understand why they occur. What do you think, what would happen if our electrical system was working and it kept sending or generating the electrical impulse, but I'd had so many heart attacks here that all my muscle was dead? What would happen? Would I get good circulation? No. That's just like flipping the switch. I've got good electrical current, but the bulb's out. So if this tissue here is dead, the heart muscle's dead, which is what happens in a heart attack. The heart muscle dies. If that muscle dies, it doesn't matter how many times you poke it with a cattle prod, nothing's going to happen because the tissue's dead. No matter how many times I flip that switch, if the bulb's out, nothing's going to happen. So that's what we're talking about here. The bulb is out, or maybe out. So that's the cardiac conduction system. Y'all like that? Yeah, we're loving that. Where'd I put that thing down? So what are the little fibers called that surround the ventricles? Purkinje fibers. What is the little bunch of fibers that feed the Purkinje fibers? The bundle of His. What is going to be the main pacemaker of the heart? The one that sets it all in motion? The SA node, sinoatrial node, also known as the sinus node. That's right. Okay, briefly we're going to look at the arteries, the coronary arteries. The coronary arteries are the arteries that provide blood and oxygen to the heart itself. So this is not arteries like we think of roaming through the body. They spring directly off of the aorta, and they're going to give first blood to the heart. So the heart feeds itself first. I'm going to get the best, the most of the best, and if there's any left over, I'll send it through the rest of the body. But it's going to feed itself first. So when you think about, remember I talked about the workload of the heart, where do you think most of the coronary arteries are going to be found? The left ventricle, that's right. They're going to be right down here because that's where the left side of the heart is. Now you have to encompass the entire heart, but there's a preponderance of them on the left side because that's the workhorse. So you got left and right coronary arteries. As they break off, the left, of course, goes to the left, the right goes to the right. We have ascending, the anterior descending branch. We also have a posterior descending branch in the back. Remember I said a minute ago, the base of the heart is the top, and what's the bottom of the heart? Apex. I'm going to see that again. Okay, this is nothing new, I don't think, to you. So veins, what do veins do? What are the function of veins? They're going to return blood to the heart. That's right. Most of the time it's carrying what kind of blood? The oxygenated blood. And so the opposite is going to be the arteries. So right here we've got the capillary beds, and that's where gas exchange occurs. What type of respiration occurs here? Yeah, internal respiration. Internal respiration is what occurs at the capillary beds. External respiration occurs where? In the lungs, at the alveoli. That's correct. So we got the veins. As veins get smaller and smaller, they become venules, and then they become capillaries. And capillaries, are they part of the venous system, or are they part of the arterial system? Yeah, they're both. That's right. They're melding between the two. So capillary beds are where gas exchange occurs. And either they're picking up oxygen or they're off-gassing oxygen, depending on which system they're coming through. When you palpate, right in here, palpate means to feel. So when you feel right here, you're feeling for your pulse. What are you feeling for here? Yeah, you're feeling an artery. What artery is that? It's going to be your radial artery. That's exactly right. And we feel the radial artery here simply because it's convenient. Arteries typically are deeper in our body, while veins are a little bit higher in our body. Like if you look at somebody, like you look at my arm, these little blue things, are those veins or are those arteries? These are going to be veins, so they're usually much higher, whereas your arteries are a little bit deeper. But in this case, we have an artery that is shallow and it runs over a bone, so it makes it very easy for us to feel that pulse. It's difficult to feel, a pulse, an artery that's deep in your body. If it's down in here, I'm not going to be able to feel it. So we're always going to feel it where it runs over a bone where it's easy to feel. Unless like the carotid, it's a very large artery, so it's easy to feel. But sometimes even pressing on that can be challenging because there's nothing behind it. There's nothing firm behind it for you to press against. So we don't have many places where we can really feel an arterial pulse. And you're not going to feel a pulse in a vein. Okay, next, let's look at what our fluid is made up of. We actually have formed parts and we have liquid parts. What are the formed parts of blood, the solid parts of blood?
Blood cells.
Yes, blood cells. Does any know blood cells? We got white blood cells. What do white blood cells do? Fight infection. Doing good so far. We got white ones. What else we got in there? Red blood cells. And what do red blood cells do for us? They carry oxygen on what molecule? On the hemoglobin molecule. And what's the other formed part of our blood? Platelets. And what do platelets do? Yeah, they allow for clotting. As they break apart, they release substances that will cause a blood clot. So what's the liquid part of blood? Plasma. Good work. See? Y'all are awake. Plasma makes up over half of the blood volume, and the rest is going to be your formed parts. Red blood cells, also known as, y'all ever heard them called corpuscles? Red corpuscles? You have? See, that's a really old term. White blood cells, leukocytes, white corpuscles, white blood cells, and then platelets. So, okay, your pulse, when you feel a pulse, when you palpate a pulse, that means touch or feel for a pulse, you're going to have to feel for that over a bone so that you can compress it and feel for it. So that pulse represents the contraction of what ventricle? The left ventricle, that's right. That's the one that pumps it back to the heart. So if you get a nice, strong, contraction of the heart, should you have a nice, strong pulse? Yeah. If there's not a whole lot of blood in the heart, how big a contraction can you get? I mean, it can squeeze, but if there's no blood in there, you're going to get a very weak pulse. So pulse is where we feel for the motion of the blood as it passes through an artery over a bone. Okay, we've got peripheral pulses and we have central pulses. Peripheral pulses are going to be anything that's not central. Central, what are you looking at? Is there a bug up there? Huh? Okay. Central is going to be basically your torso. Anything through here is considered central. Everything else is considered peripheral. Peripheral means what? Well, think about it. P-E-R-I? It's around. That's going to be out there somewhere. It's going to be out there. Whereas central is going to be the core part of the body. So specifically the pulses that we're going to be feeling for, the peripheral pulse, the radial is a peripheral pulse because it's not part of the core. The brachial pulse, where's that? By the brachial bone? Yeah. Your brachial artery is going to be right through here. And if you can press on that and press it against the bone there. Against what bone? The humerus, that's right. If you press on that, not like this, but with your fingers spread out, you can put your arm to sleep in a hurry, which might be important if you're gushing blood from up here. You can use a pressure point here to help slow the bleeding. We also have the posterior tibial. Where do you think that is? Posterior means what? Back. And where's the tibial? That would be the tibia, right? We're going to basically palpate that right behind the knee. So that's something you can practice at home. And we also check the dorsalis pedis. Okay, you know where that is? Yeah, it's going to be the top of the foot. And we'll talk later about how to identify that. And that will be one that we check very frequently. We'll check the dorsalis pedis, or we may call it a pedal pulse, because it's going to be the top of the foot. On the central area, we don't have many choices. Our only one is going to be the carotid pulse. So you can check a carotid pulse, and we'll practice that in the... And you may have the opportunity to check a femoral pulse. They're difficult to feel. I've done it a few times in the hospital, but in the field, not so much. But it is another central pulse that you can check. And to check the femoral pulse, it's going to be located right here at the bend, like where you bend your leg. And if you can bend the leg slightly, press your hand, your fingers right into that, you may be able to feel a pulse. Usually this is used as a pressure point where you can help to control bleeding by putting the pressure with the heel of your hand. But as far as palpating a pulse there, it's very difficult to do. Central pulses. We're going to use a central pulse, primarily the carotid pulse, just to determine if your patient is dead or not, if they're pulseless. You know, if you feel up here and you can't feel a pulse, probably a good chance that they're dead. The only time that it wouldn't be so much is if we're talking about a patient that's severely hypothermic. Carotid pulse. To locate your carotid pulse, first you'll find the Adam's apple, and then you'll slide into the groove or depression to the side of the neck. If you're checking this on a patient and they're laying down in front of you, notice here he's pulled his fingers towards himself rather than away. What happens is if you're feeling for a pulse and you're feeling on the opposite side, you run a great risk of actually closing off both carotid pulses. So you want to make sure you slide your finger towards yourself. Brachial pulse, I showed you that one. Radial pulse. When you check the radial pulse, you're pressing over the radial bone, which is going to be on the thumb side. So somebody was waving the thumb here. On the thumb side, and it may take you a minute to locate that, but do that for me. I want you to feel your own pulse first. Don't use your thumb, because your thumb has its own pulse, you know. So use your fingers. What I'd like to do is spread them out, and then when you feel it under there, then you can zero in by moving your fingertips over it. You can feel it better. Did you find your pulse? Did you find it? Everybody find it? Good. Find your seat mates. Let's see how good you're going. What do you think you're looking for? You're looking for a pulse, but what other things do you think you're looking for? you that if the ventricle is working very well, it's pumping very strong, you're going to have a nice strong pulse. If there's not a lot of blood, you might have a weak pulse, right? Everybody find yours and your buddies? Anybody not find that? So yeah, when you're palpating, which means to feel, when you're palpating for a pulse, you want to know if it's fast or slow, or non-existent, right? You want to know if it's strong or weak, right? What else might you notice? Did anybody notice anything weird about your buddy's pulse when you're feeling it? Anything weird? Well, it's not uncommon for a person to have an irregular pulse for one reason or another. So you want to know if is it fast, is it slow, is it weak, is it strong, is it regular, is it irregular? So you can tell all of that just by a short palpation there. Now I didn't ask you to count it. We'll count later when we're getting vital signs, but just by placing it here, you can tell if it's fast or slow. You know, if it's going duh, 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 is that fast? Not so much. If it's going duh, duh, that slow? Yeah, that's when you pass out and we all pounce on you. So you do not want to pass out in this classroom because we need a guinea pig. Okay, femoral pulse, as I mentioned to you, it's going to be right at the bend of the leg there. Dorsalis pedis. And there are different ways where you can identify this. Let me make one recommendation to you. Once you palpate that dorsalis pedis, make a little mark on it with your pen for a trauma patient. Make a little X right there so you can remember where it was. Because after a little while, you may have to come back and recheck that. And if you can't find it, you go, where was that pulse? But if you got a little X right there, you go right to it. And if you don't feel it, then you know you have a problem. But now this is something you need to be practicing at home. I know it sounds really weird. You know, kind of check your feet. But yeah, people that know you and love you might let you check their feet. But see if you can't find a dorsalis pedis pulse. You may have more difficulty doing it on yourself, but check on people around you and see if you can find this pulse. It's more difficult than you think. Okay, let's talk about blood pressure here for a few minutes. Because that's one of the things we do. We check blood pressures. It's kind of fun. We'll start doing that in the lab, I think probably next week. Give you guys time to get your stethoscopes back. The blood pressure is measuring the pressure or the strength of the contraction of the heart. So that's what we're looking for. Blood pressure is going to indicate to you how well the body is perfusing. Perfusion is going to be the delivery of oxygen and nutrients to the body and the removal of waste products. I think I talked about that the other day. So blood pressure is going to be the pressure that's inside the arteries. So we've got two components of blood pressure. We've got the systolic and the diastolic. So you can think of it like this, systolic and diastolic. Okay, here is a prefix for you. What does this prefix mean? Okay, all you guys have watched all of those shows on television where they get in there and they're defibrillating the patient in the ER because he's flatline without. Yeah, so what's that word they say for flatline? Asystole. That's an A. Asystole. So that means without, basically, a contraction. That's what that means. So without contraction. So systolic or systole is what? The state of contraction. If this means without contraction, then this means contraction. So systole is going to represent the contraction of the heart. So that's going to be the upper number. And it's going to be the biggest because when that ventricle contracts, that's when you're going to get the most pressure. Diastole, which is diastolic, represents the pressure that's left in the vessel after systole. So you got the big pulse that moves through there, that big contraction, but after it goes, what have you got? The resting part, or the resting state of the vessel, but there's still going to be pressure left in there. So that's going to be diastole. So the biggest number is going to be called what? Systolic. The smaller number is diastolic. So 120/80 is kind of like what they call the norm. Very few patients ever have that. But so 120 represents what? Systolic, which is the pressure in the vessel when what happens? The ventricle contracts. Diastole represents what? The resting pressure that's going to be left in the vessel. So that's what we're wanting to know. And what these numbers are, what they represent, we'll talk about as we move through the semester. So we know A stands for what? Without. That's right. Okay, I mentioned perfusion. That's a term you have to be very sure about what that means. Perfusion indicates adequate circulation of blood, the exchange of oxygen and waste products. So oxygen is delivered to the tissues, waste products are removed. That's perfusion. So if you have, you've been stabbed and you've lost a whole bunch of blood, right? That means your fluid is pretty low. What do you think your perfusion status is going to be? Are you going to be well perfused or poorly perfused? Yeah, if you don't have a lot of fluid to move oxygen around, then your cells are not getting enough oxygen. And you're not getting waste products out of there. So perfusion is a good thing. Perfusion depends on blood pressure. If the blood pressure is really, really low and the heart just can't send all that fluid down to the toes, are you poorly perfused? Yeah. Even if you have plenty of blood, even if your vessels are good, if the pump's not working, you're going to be poorly perfused. If there's not enough blood volume, you're going to be poorly perfused. If the heart can't get it around, you're going to be poorly perfused. So there are a lot of reasons that your patient could be poorly perfused. So one of the things you're going to have to do is try to determine why they're poorly perfused to see if there's something you can do about it. Since perfusion requires oxygen to the tissues, say you're choking and you've got an airway blockage. Your heart's working good. Your pipes are working good. Your pump's working good. Can you be well perfused? Yeah, I've got airway obstruction, but I got plenty of blood. My vascular system's working good. My heart's working good. Can I be perfused well? No?
No.
Yes? No?
No.
Why no?
Because you're, can't breathe.
I can't breathe, but does that stop the circulation to my tissues? I'm still getting all the blood around, aren't I?
The blood is oxygen.
Yeah, exactly. Yeah, the blood's not oxygenated. So without getting oxygen to the tissues, I'm not going to be well perfused. So there are a lot of aspects to that. So how would you recognize if you say your patient had a blocked airway and all the other parts are working, it's just not getting air? How are you going to be able to look at your patient and tell they've been without oxygen for 3 minutes? Yeah, they're going to become cyanotic. You know that word? Ooh. Blue. That is exactly right. Cyanotic. Y'all ever change your printer cartridge? You know, it's always got all the colors on there. That's blue. Blue pen. I mean, cyanotic means blue. Okay, so perfusion is going to be the delivery of oxygen to the tissues and the removal of waste products. So a lot of things go into or factor into perfusion. So that's something we'll talk about as we move on along. So hypo, we know what hypo means, right? Low. So hypoperfusion, that means if your patient's not getting oxygen to the tissues for whatever reason, they're going to go into shock. Their body is shocked by the lack of oxygen to the tissues. So oxygen is just one of the requirements for tissues, for cells to be healthy. A few other things go into that, but if you're not able to get oxygen to the tissues, your patient's going to be shocking. It might be because of low circulating blood volume. It could be just from an airway compromise where they're not getting oxygen in there. So a lot of different reasons. It could be because the heart can't pump it. So anytime the flow is interfered with, whether it's the fluid or what the fluid's carrying, then you're going to have shock in a patient. Okay, here's a tough one for you. How is the function of the respiratory system related to the function of the circulatory system? You what? Yep, if the respiratory system's not working, like the example I just gave, you've got a blocked airway, the respiratory system's not working. The circulatory system can just keep on going until the cells are completely out of oxygen, and then it's going to stop too, right? So they have to work together. Just because you're breathing really good, just because you're bagging your patient, you're getting the air in there, if the circulatory system's not working, it's all for naught. So they are interdependent. Okay, next body system, the central nervous system. What makes up the central nervous system? The brain and the spinal cord. Just the things right here in red. The brain and the spinal cord is the central nervous system. Now, the peripheral nervous system is going to be what? Everything else. It's kind of like when we were talking about the central here, central pulses versus peripheral pulses. Same thing. With the peripheral nervous system, that's going to be everything else. There are two main categories of peripheral nerves that I just want to touch on here. We've got sensory nerves and motor nerves. So if I put my hand on a hot stove, really a couple things happen here. As soon as I put my hand on a hot stove, what happens? What's the first thing that happens? Yeah, sensory nerve goes, oh my gosh, you're stupid. You put your hand on the hot stove. So it's going to notify the brain, stove's hot, and then what's going to happen? Yeah, the brain's going to send a message to the motor nerves that say, move it. So we actually have two things going on. Sensory picks up the sensation that there's a problem, and then the motor nerves actually do something about it. So you can have a patient that has a spinal cord injury, but they may be able to feel something, they can't move it, or vice versa. They can't feel it, well you can have nerve damage where you can't feel it, but you can still move it. So it's not necessarily, they don't go hand in hand in that if one is damaged, the other one is too. So we got sensory and motor here. So sensory takes messages from the body to the brain. Motor nerves message from the brain to the body. Digestive system, it's probably my third least favorite body system. However, I like for it to work properly. You can see parts of the digestive system are detailed in here. The things you probably need to know where they are is the pancreas. The pancreas lays right here between the stomach and the liver. The gallbladder is going to be attached to the distal end of the stomach. Kidneys, you know, the kidneys are what we call retroperitoneal. What does retro mean? You know, when y'all are really getting retro, you know, you're wearing strange things that I used to wear when I was a kid. Or as a teenager. Retro is what? Back there, behind you. So retroperitoneal, the peritoneal cavity really is the abdomen for the most part. So retroperitoneal is going to be back here. You know, you've seen them on TV when they get in a fight and they kick them in the back and they worry about kidney damage. The kidneys are way up high right here. So they're retroperitoneal. And so there are a few other organs that are back there too. Appendix, as you can see, what quadrant's that? Right or left? Right lower quadrant, that's right. Kidneys, liver, spleen. Okay. All right, that was pretty quick, wasn't it? I told you it's my least favorite. Integumentary system. Integumentary system is what? The skin. The skin actually is the largest organ system of the body. It covers the whole body. So area-wise, it covers quite an area. So there are 5 functions to skin that I kind of want you to know. What does skin do for us? It what? It protects us from what? Everything out there, yeah, it protects us from, you know, foreign invaders and sorts. What else does the skin do for us?
Temperature.
It what?
Temperature.
Yeah, it's a temperature regulator. Keeps us warm or allows us to cool off, as the case may be. What else of that sort. And what else does it do for us? A shock absorber, yeah. Some of us have more than others. I have lots of shock absorbing components in my skin. What else?
Water balance.
Water balance, yeah. We're able to sweat, which is part of excretion, but it allows us to move water out of the body and sweat, which sweat does what for us? Cools us, yeah. Let's see, protection, water balance, temperature regulation, excretion, shock absorption. Yeah, because skin is not just our top layer, which is called what? The epidermis. Yeah, it goes much deeper than that. So you can see we've got muscle and tissue, subcutaneous fat down here. This is part of the shock absorbing function of the skin. Okay, the layers, we mentioned the epidermis. What's the second layer? The dermis. And the third layer? The subcutaneous layer. Yeah, and there are other layers below that that we can go on up the program we'll talk about. But for us, these are the three main ones. So we know what the epidermis mainly does, but the dermis is where we've got our sebaceous glands, we've got some nerve endings in here, we've got some vascular system that runs down through here, both venous and arterial, and then we've got our fat layer. And what does our fat layer do for us mostly? That's going to be our insulation and our shock absorber. That's right. Boy, that was quick, wasn't it? Endocrine system. Now, the endocrine system is important to us because probably one of your more common medical calls that you'll have that has to do with the endocrine system would be what? Yeah, you have a diabetic emergency. Low blood sugar or extremely high blood sugar. Blood sugar is going to be regulated via the pancreas. So the pancreas, what does it do that's so important? It secretes something important. Insulin, absolutely right. So we will look at that at depth as we move along too. See, the pancreas is loaded. That made sense. The pancreas is going to be right up here close to the kidneys. Right there. There it is. The thyroid, we see patients with thyroid deficiencies sometimes or overactive thyroid, but usually that's not an emergency. You may have a history on a patient that has thyroid problems, but it's usually not the basis of a 911 call. So the endocrine system regulates excretion of hormones and spread throughout the body to regulate the actions of the organ systems. Pretty quick. The renal system, this would probably be my least favorite. The renal system, we do interact frequently with patients with renal system issues. What would those issues be? Who are these patients? Old people, maybe, sometimes. Well, these, yeah, we're talking about kidney failure here. So patients with kidney failure, in EMS, we seem to transfer a lot of patients with kidney failure to dialysis, where they have to have their blood cleaned. So that's when we really look at kidney failure is going to be the cause of a lot of our calls. So the renal system helps regulate fluids, fluid balance, and removing or maintaining a proper pH in our body. And pH is important. Well, I don't think we cover that well in here at all, but pH is important. That's going to regulate whether we're acidotic, meaning we have a lot of acid in our body, or whether we're more base, where we're alkalotic. But we cover that in depth at the higher levels. Reproductive system, but the only thing we're really concerned about here as far as reproductive is usually female reproduction, if they're having a baby or they have an ectopic pregnancy. Most of your issues with the male reproductive system are usually not 911 calls. But we'll look at this at depth when we get to those chapters. Okay, y'all ready for chapter review? Yeah. That's always a good sign. Let's see. Make sure y'all don't leave yet, okay? So just kind of take a deep breath and know we're here for a few more minutes, okay? Make sure that in your reading, if there are any words that you don't understand or you don't know what they are, write them down. Make a note card. I can't remember if I mentioned this early on, but National Registry, they expect you to know, a minimum amount of medical terminology. So you need to start looking for these words. When you see them in your reading, in your textbook, don't know what they are, write them down. It's important that you use words correctly. Now the difference between a prefix and a suffix. Where does a prefix occur? The beginning of a word. Suffix at the end. Okay, good. Your knowledge of anatomy, which is the structure, and the function, which is physiology, of the body is going to be very important to you being able to properly assess your patient and then make a determination about treatment. So if you don't understand the anatomy and physiology, you're not going to be able to do your job. So this stuff, what we've done is fairly easy. So you got to understand it. Body systems: musculoskeletal, respiratory, cardiac, nervous, digestive, integumentary, which is what? Integumentary? Skin. Okay. Yeah. All right. You need to make sure that when you're using medical terms that you use them correctly. There are a lot of words, particularly when you start looking at drugs, that are, except for one letter in a word that's got 20 letters, one letter can change it into something completely different. So make sure you're using the correct word. If you're not sure about it, just use plain English. Don't mess yourself up there. Make sure you know where critical organs are located in the body. If you have a patient with a serious traumatic injury to the abdomen, you need to know, well, gee, this organ's here, that organ's there. You know, where's the liver? You know, if you see a big something hanging out from a cut right down here, do you think that's going to be the liver? Probably not. So you need to know where the organs essentially are so you can recognize when your patient's complaining of something. All right, I want you guys to think. Respond to a teenage boy who has taken a hard fall from his dirt bike. He has a deep gash on the outside of his left arm. Got that? Which arm's that? Okay, on the left side? Okay, deep gash on the outside of his left arm, halfway between his shoulder and his elbow, and another on the inside of his right arm just above the wrist. His left leg is bent at a funny angle, about halfway between the hip and the knee. All right, you got all that? Have you visualized that on yourself? You see that patient? He doesn't feel good, does he? When you cut away his pants legs, you see a bone sticking out of a wound on the front side. How would you describe this patient's injury? How would you describe the injury to the thigh? Critical, yeah. Is it left or right? Okay, which bone is it? It's a femur fracture. And it says it's sticking out of the wound on the front side. So, anterior maybe. You don't see many posterior of these. You might call this a mid-shaft to differentiate it from the ball of the femur head. Remember we talked about the femur head. You're not probably going to be able to tell exactly where that break is. So it's mid-shaft on the right side. So we call that a mid-shaft right femur fracture. I'm not going to make you write that out. But you need to think about describing these because you're going to be writing that in your documentation. So when you're out on your clinicals and you get this patient, you know, who is involved in a head-on collision and he's got a femur fracture, what else was wrong with him? Let's see. He's got a gash on his left arm halfway between the shoulder and the elbow. So halfway, the outside of his arm. So what would we call that? How would you describe the outside of his arm? It's going to be right out here. Where is it here? It's going to be lateral because we're always going to describe a patient from this anatomical position. So if it's on the outside, it's going to be lateral. So you describe that as lateral. And you might say mid-shaft because if it's right in the middle. His left leg is bent. Oh, I did that one. Right arm. Right arm just above the wrist. This is my right arm. Right. Above the wrist, so it's going to be proximal to the wrist. That's going to mean it's above the wrist, but it's close to the wrist. You might say distal to the elbow. That would mean it's far from the elbow. So that would indicate that it was just above the wrist there. Okay, you ready for a quiz? What does cardio mean? Heart. What does tachy mean? Fast. Hemo. Blood. Thorax. Chest. What type of muscle can generate its own electrical stimulus? Yeah, it's in the type of muscle is going to be cardiac muscle. And what do you call its ability? Automaticity. The movement of air in and out of the lungs is ventilation. That's right. That's just movement of air in and out. What's the largest chamber of the heart? The left ventricle. What's the primary pacemaker of the heart? The SA node. Good work. Draw the shape of the diaphragm when it is relaxed. Which is it? Come on, y'all. Come here. Do a little dance move. Is it this move or is it this move? Plie. That's right. It's relax. Is that what we're saying? Relax is going to be up. Okay. Y'all moving. At least I know you're awake. The top of the heart is called the base. Ta-da! Okay. Tomorrow night's lab, make sure you bring your pen light. Bring something to write with. I'm going to give you out some papers. And we're going to start on some of our skills, okay? See, at 5 o'clock, I didn't show you the lab, but let me tell you where it is. You know where you come in to where Miss Libby is and the advisors? You're looking right at their office. You're going to go down to the left. So when you come in the building, you're going to go off to the left as far as you can go, and then you'll see a sign on the door on the right, and it says EMS lab. I'll meet you guys down there, okay? Good job. Y'all were good tonight. I appreciate it.